So we are going to be talking about nasogastric intubation, or NG tubes. So you'll see these a lot in the hospital. So we're going to talk about how to care for them, how to assess patients with them, how to feed patients through them, and give them medications as well. We're going to talk about the different kinds of NG tubes and when they might be indicated. Okay, so what is a nasogastric tube? So this is a tube inserted through one of the nostrils, down the nasopharynx, through the esophagus, and into the stomach. So it's a tube going from the nose to the stomach, so naso for nose and gastric for stomach. All right, and then here is just a picture. You can see where the tube goes in through the nose, nasopharynx, oropharynx, or just nasopharynx, sorry, larynx, and down into the stomach there. Okay, so some different indications for nasogastric tubes. We can use it to help decompress the stomach. So if somebody has had abdominal surgery or they have maybe some kind of bowel blockage and their stomach is very distended, we can use this, hook it up to suction to help decompress. We can also do what's called a lavage. If you've ever heard of someone getting their stomach pumped, from alcohol intoxication, or they've ingested something toxic, this is what the lavage is. So it's basically where we can instill, fluid or whatever in the stomach and then suction everything out to try and get rid of that toxin. We can use it to give medications and feedings. And then aspirate. So when we talk about aspirate in this sense, we are talking about pulling something out of the stomach. So pulling out stomach contents. We're going to talk a little bit more about this when we talk about verifying placement. We can also give it to patients who are experiencing extreme nausea to help kind of keep things off of their stomach. Okay, so clients who are at risk for aspiration. So when we're talking about aspiration here, we are talking about the stomach contents going into the lungs, okay? So normally whenever, you swallow something and it goes down the wrong way, quote unquote, that would be considered aspirating. We usually cough. Healthy individuals will be able to cough and get that out of their lungs. But we want to be careful since we are inserting this into the esophagus, that is right next to the trachea. We want to be careful to not cause any kind of aspiration due to this, and we want to be careful not to insert the tube into the lungs because that could cause respiratory distress. So some things that make a client at risk for aspiration would be decreased level of consciousness. So if they are very lethargic or not awake for whatever reason. Some patients have poor cough or gag reflexes. A lot of times patients who have had a stroke, they may have trouble swallowing. So this would be someone who would be at risk for aspiration. If they have had recent endotracheal intubation or current endotracheal intubation, so this would be someone who's likely in the ICU that has like a breathing tube in. So they have a tube that's going into their lungs. So if we insert another tube, they're at risk for going in the lungs rather than into the stomach. If they're unable to cooperate with the procedure, so sometimes kids or an older adult who's maybe confused or someone who is combative, if they're moving around and you're trying to insert this tube and they're thrashing everywhere, they're going to be at higher risk for aspirating. And that goes hand in hand with restlessness or agitation. So you want to assess this before you place an NG tube. Okay, and this is just a little review of the epiglottis so you can kind of visualize, you know, what's going on when you're inserting the tube. So we know our epiglottis closes whenever we swallow, so it's here, and it closes over our airway so that we don't aspirate, okay? So it opens when we breathe so the air can come in, okay? So this is why, and we'll talk about when we insert NG tubes, this is why we try to get the patient to swallow some water. So that way that epiglottis is closed and it'll go down into the esophagus and not into the trachea. Okay. There's different types of nasogastric tubes for short-term nutritional support. So most of the time, NG tubes are not long-term. It's just a short-term thing. You do see some people who have NG tubes like chronically. Usually that's patients who maybe have eating disorders or something like that. But typically it's just for short-term while they're in the hospital. And we're going to talk about each one of these. So the Levin tube, Salem sump tube, Dobhoff tube, and then the small bore feeding tube. So the Levin tube, so this is a single lumen tube. It's flexible. It's usually either soft rubber or plastic. Again, this can be used for decompression, lavage, feeding, or suction. If this one is hooked up to suction, it needs to only be intermittently, meaning not continuous, okay? And we're going to kind of talk about why on the next slide. But this is usually just for short term. This is not probably going to be the one that you're going to grab for most often. So your Salem sump tube, this is your double lumen. This is the one you're probably going to see most commonly, okay? It has a larger tube that's ideal for draining stomach contents. The smaller tube, the blue tube right here, that is used for the inflow of atmospheric air. So it helps to prevent a vacuum from occurring that causes the tip of the tube in the stomach to kind of vacuum or suction to the side of the stomach. Okay, so that helps with that if they are hooked up to suction, okay? So that's why with the Levin tube or the single lumen tube, we don't do that for a long period of time because it doesn't have that airflow tube that helps prevent that suction. So a lot of times it will get suctioned to the side of the stomach wall. So the Salem sump tube is best for that. And we want to make sure that the blue part here, there's only air in there. If stomach contents, feeding, whatever gets in there, then we want to make sure that we're clearing that out and that air remains in there. Otherwise, this tube could become suctioned to the side of the gastric wall as well. Okay, and then our Dobhoff tube. This is usually ordered specifically, but it has a weight on the end of it. So it's a little smaller, more pliable, meaning it can bend a little bit easier. It's a polyurethane tube, and it's usually inserted with a stylet. And that's just to help get it, make sure it gets in the right spot. And then we also have a small bore feeding tube. So this is, these might be longer. So they may go into the small intestine or the jejunal tube, or it goes into the jejunum. So it's going into the small intestine. So this is usually used for feeding. It also helps prevent the risk of aspiration because it's so long and it goes into the jejunum. It's usually used for enteral feeding, and especially, again, for clients who are at risk for aspiration. It is usually a little bit more comfortable just because it is smaller, it's a little bit more pliable, like the Doppelt tube is as well. But you have to be careful with these because they're probably going to come out easier than your Salem sump or your Levin tube. I had a patient before that had a Doppelt in, and it came out twice in one shift, just moving him to the chair. It was secured and everything, but it just kept coming out. So eventually I ended up putting in a Salem sump tube to keep it so it wouldn't keep sliding out. Okay, so contraindication. So this is a reason that we would not put an NG tube in. It would be contraindicated, so it could cause more harm to the patient than good. So contraindications would be a suspected or known basilar skull fracture or any kind of maxillofacial trauma. So if you're working in the ER or something like that and someone comes in with major trauma to their face, we're not going to be inserting an NG tube, okay? Because we don't know where that tube is necessarily going to go if some bones are broken in the face. So we don't want it to go to the brain, to anywhere it's not supposed to be. You also want to be careful with patients who have nasal polyps and with patients who are on anticoagulants because they're more likely to bleed. So when we put an NG tube in, it can cause some trauma, so we want to be careful with that. We don't want to cause them to bleed and then have trouble getting it to stop. Okay. So when you are getting ready to insert the tube, so say you have an order for a patient to have an NG tube placed, you've selected the correct tube. Usually if it's just an NG tube, it's gonna be a Salem sump, but unless otherwise indicated by the physician's order. So first we have to make sure the nares, that the nose is patent. So we can do this by occluding one nostril, having them breathe through it, and then occluding the other nostril and making sure they can breathe through both of them. So that's how we assess for patency. We want to know their medical history. We want to know if they have any background that we need to know about, anything that might contraindicate this, or anything that we need to be aware of while we're putting this down. Determine the presence of a gag reflex. So we want to make sure that they can gag, they can cough, so that way we don't risk aspirating. You can do this with like a tongue depressor or something like that. I will say I do not usually try to gag my patients before I put this in, but I do kind of try to be aware of, if they're probably an aspiration risk or not. And then we're going to assess mental status or ability to cooperate with the procedure. So can they follow directions? Will they be able to cooperate to prevent any complications while we're inserting? Okay, so once you have your supplies, you're going to always measure your NG tube first. Okay, so how we do this, and you'll practice this in lab, is we take the very end of it, we put it by the nose, and then we go to the earlobe, and then down to the xiphoid process. So that is the pointy part of your sternum. So you can see down where they're holding it. You can maybe feel on yourself. But it's in between where the ribs come together at the bottom, and it's kind of a little pointy part. And that is how you should measure it. So once you've measured it, you need to mark it. You can either do this with tape or a Sharpie. Sometimes they have like markings on them, and so if you remember like what number it's at and you document that, that's okay too. Alright, so equipment used for inserting a nasogastric tube. Again, we're going to choose the appropriate tube. Clean gloves, so universal precautions, so we could will come in contact with bodily fluids doing this, so we want to wear gloves. Use of water-soluble lubricant. So this is to help to put on the tip of the NG tube to help it go down easier, to make it a little bit more comfortable for the patient. So we are going to always, anytime we're using some kind of lubricant, it needs to be water soluble, okay? If it's oil-based, like petroleum jelly or something like that, we don't use that in the hospital because, one, if someone's on oxygen, that creates a high risk for a spark occurring. And then oxygen is combustible. We'll learn about that in the oxygenation lecture, but it is combustible, so it could cause an explosion. So that can be very dangerous, so we don't want to do that. It's also the most like, like our body composition. We're made up of a lot of water, so it's going to kind of dissolve better than if we were like sticking oil down in it and getting all funky. So water-soluble lubricant, okay? And then we might also have an emesis basin, so something if the patient needs to throw up, because we could potentially be gagging this patient because of where we're sticking the tube at, so they might throw up. So that's normal. If it happens, you just kind of want to be prepared. A glass of drinking water with a straw. We'll talk about why we have this in a minute. Tissues in case their eyes or nose or whatever start running. Either 1-inch tape or commercial fixation device. So some facilities have like a specific securement device for NG tubes, or you can use a piece of tape to secure it as well. A towel, a suction apparatus, so something to be able to suction out their mouth if you need to, or if they are going to be started on suction, like the NG tube is supposed to go to suction, then we want to have that prepared as well. A pH test strip or meter, if this is available at your facility. Talk about why we need that. Stethoscope. A safety pin and elastic band. This is just to help secure it. And then a 20 to 50 ml syringe. I'll say at St. Bernard's, they're called piston syringes, and they're usually 60 mils. And that's probably what they have at NEA as well. Okay, so for preparation, you're going to, as always, explain what you're going to do. You're going to make sure, they're okay with it and everything, and they understand why they're getting it and what to expect during the procedure. So I would tell them that it's going to be pretty uncomfortable. It may make them cough, it may make them gag, but if at any point they feel like they can't breathe, or they're becoming into respiratory distress, you want to establish a signal. So some hand signal. That way they can let you know they're in distress, you need to pause. Okay? We're going to place the client in high Fowler's position, so this is going to make it less likely for them to aspirate. And then we're just going to place a towel across the chest just to make sure, protect their gown, if they do get sick or something like that. So when we're ready to insert, we're going to check for patency of the nares. We talked about that. We talked about measuring, so make sure we've measured. And then initially when we're about to insert, well, I would probably lubricate the end of the tube before I had my patient do this. But lubricate the end of the tube with water-soluble lubricant. And then you're going to have the client extend their neck back against the pillow. And then start to insert the tube following the nasal passage. Okay? So you're going to kind of rotate the tube to help it pass through the nasopharynx a little bit better. Because sometimes if you just pass it straight through, it'll kind of get stuck on the mucosa or whatever. I kind of think of this as like when you're going down a slide with shorts on and your skin gets stuck. Kind of like that. You have to kind of move to get it unstuck. So that's kind of why you want to kind of rotate it a little bit. And then once you get to the back of the throat, usually at this point you'll feel some resistance and the patient will also probably start to cough. This is when you have the client move their head forward, moving their chin to their chest. Okay? At this point, this is when we're going to give them the cup of water with a straw. we're going to have them swallow as we advance the tube, okay? So we're going to have them take small sips. As they swallow, we're going to advance the tube. So we're going to say swallow, advance, swallow, advance, okay? So what this does is, like we talked about earlier, it's going to close off that airway, okay? So our epiglottis is going to close off over our airway when we swallow. So that way we know the tube is going to go down into the stomach. Okay, so once we get the tube in to our marker, okay, we can kind of loosely secure it because we need to check for placement, okay? So even though we measured it and everything, that doesn't mean that it's in the right spot, okay? So we don't ever use an NG tube for any reason if we have not confirmed its placement, okay? So once it is initially inserted, we will check for placement by getting an x-ray, okay? So we will get an x-ray of the abdomen. That's how we're going to do it initially, okay? Then after that, every other time, we're going to check in a different way. So we're not going to get an x-ray every single time. There's no need to do that and expose the patient to more radiation than necessary. So after the initial time, usually the physician, the doctor, will look at it after the radiologist has read it and give an okay to use order for the NG tube. Okay, so other ways to check is measuring the tube length at the tube marking, so making sure it's still in the right place as it's marked. Measuring the aspirate pH, so that would be we would take our syringe, hook it to the end of the NG tube and pull back some gastric contents. And then we're going to test the pH, okay? We're going to talk about how to know when it's in the stomach based on the pH. Visual appearance of the aspirate, we're going to talk about this as well. So does it look like gastric contents? And then also monitoring the carbon dioxide. Okay, we'll talk about this as well. So this is standard procedure to verify initial placement. So you can see here, they have got, you can see the NG tube going down and in, it looks like it's into the stomach, okay? Now, I don't expect y'all to be able to read this necessarily, but the radiologist will. But this is what they'll look like to make sure that it's in, the tip of it is in the stomach. Okay, and then again, measurement of the tube length. So whatever that measurement was when you first inserted it, and you have confirmation by a chest x-ray or an x-ray, then that's another confirmation that it's still in the right place. Okay, so testing the aspirate pH. So this is important. Make sure you know this, okay? So make sure that you do this if they've had medication or just completed an intermittent feeding, meaning they're not on continuous feedings. You would want to make sure you wait an hour before checking this, okay? Otherwise, the pH will probably be off. Okay? So a pH of 5.5 or lower, okay? Because lower is more acidic. 5.5 or lower, the placement is in the stomach, okay? So if my pH is 4, I'm good. I'm in the stomach because it's 5.5 or lower, okay? Respiratory, so if this is in my lungs, they are going to have a pH of 6 or higher, okay? And then if I've gone down too far, I'm into the intestines and I'm supposed to be in the stomach, that will show a pH of 7 or higher, okay? And then if we are aspirating and we are just going to look at the gastric acid or gastric contents, it should have a grassy green look with probably some particles in it. It may be tan, off-white, and depending on what the patient has going on, they may have a little blood in it or it might be brown as well. All right, another way we can confirm placement is using capnography. This is not something that I've seen routinely done, but it may be at whatever facility you end up working at. So you just basically hook the little capnography up, and then depending on the color that it shows, that shows you if CO2 is detected or not. So we know that when we're inhaling, we're breathing in oxygen and exhaling CO2, okay? So CO2 would be detected in our lungs. Really, it won't be detected anywhere else. So if it is detected, it's in our lungs. So this still doesn't confirm, even if it says no CO2 or whatever, it still doesn't confirm that the tip of it is exactly in the GI tract, but it at least tells us it's not in the lungs. Okay, so if our patient, we have an NG tube on our patient and we are planning to hook them up to suction per physician orders, we want to make sure that obviously we do an assessment before and throughout their treatment. Okay, so we're going to look for presence of abdominal distension. So is their stomach distended? Is it kind of firm? Is it causing discomfort? We're going to auscultate or listen to bowel sounds with our stethoscope. And then we're going to get vital signs for baseline data. So we're going to make sure we know what their vital signs were before we started. So after we start, we can compare. And if there's a big change, they might not be tolerating the suction well. Ideally, when we start this suction, some of the abdominal distension and discomfort should decrease. So we want to monitor for that. Okay, so for GI suction, continuous or intermittent, this is usually per physician order. If they're on continuous, it should be on low wall suction. So you see here, this is your like flow meter that's on the wall, that you'll see on the wall in the patient rooms. In the green here, this would be considered low wall suction. So usually they'll have ordered for that, and that's what that means. It should be in the green here. Or sometimes they'll say to 20. All right. So that's usually continuous. If it's ordered for continuous, it's usually low wall suction. Intermittent, this just means not continuously, just probably as needed. So if you need to hook them up for whatever reason, or if you have some physician orders that call for intermittent, that just means the suction's not going to be running constantly. Okay, so then we're going to talk about assessing the client and the suction system after initiation of the GI suction, okay? So we've hooked them up to suction. Now we're going to monitor every 30 minutes until the system is running effectively, okay? And then after that, we're going to make sure we're assessing the patient and then the suction system at least every hour or every 2 hours, or, as needed. So we're going to inspect the system for patency and tightness of the connections. So when you get into the hospital, you'll see different versions of this, but they're going to have a canister that you see here. So you need to make sure the lid is on there securely, all these little caps are on any open parts, and that all of the tubing is secured. If it's not secured, then it's not going to suction. So we want to make sure that it's doing its job, that we have it hooked up to our flow meter, that it's going at the appropriate amount of suction. Okay, so one complication of having an NG tube is, becoming blocked. It's easier to prevent this than to correct it, so we'll talk about that. But if we do suspect a blockage, so maybe if they've been doing fine, maybe some of their distension was relieved, some of their discomfort was relieved, but then all of a sudden it comes back. Could be a blockage, could be something else. Or if we're trying to give medications or an enteral feeding and it won't go down, you're getting a lot of resistance, it's not wanting to drain into the NG tube, then we might have a blockage as well. You can try to reposition the client. Sometimes it kind of just gets up against that gastric wall, especially if it's not like a Salem sump tube, and that might fix it. You can also try to rotate the NG tube and reposition it if needed. If the patient's had some kind of gastric surgery, so surgery on their stomach, then we have to be very careful with NG tubes because we don't want to poke in sutures or anything like that, cause them to bleed or do anything with any of the integrity of what's been sutured. So if your patient comes up with an NG tube after gastric surgery, we're not going to do a lot with it unless a physician gives us an order to, okay? And then we can irrigate the tube. So we can get some sterile water. You can use tap water, but if the patient is immunocompromised, then you need to use sterile water. And that's usually in the supply pixis at the facility. So you'll use your piston syringe and put some just normal or sterile water down it to kind of flush it out. But good prevention with this is, flushing it regularly, making sure after you give medications that you use some sterile water or water after it to make sure everything's getting flushed out and not building up and causing a clog. Okay, so preventing reflux in the vent lumen. So this is the little blue part of the Salem sump. So we want to prevent reflux of gastric contents into that in order for it to work appropriately. So if we keep the tubing higher than the stomach, that's going to help with that. So if we use a little safety pin and a rubber band, we can kind of use that to secure however you want to do it. But just keeping it up above the level of the stomach is going to help with that. And then keeping the drainage container, so that canister, lower than the stomach, and make sure it doesn't get too full. So if your patient is draining a lot of stuff out of their stomach and it's getting full, once it gets full, it's not going to suction anymore. Okay, so then that could cause some backflow. All right, and then ensuring client comfort. So they may have this in for days. So their nostrils are going to be uncomfortable. They might get dried out. They might get some skin breakdown around it. So you want to be monitoring that. You can kind of help them clean their nostrils using a cotton-tipped applicator and water to kind of get around the NG tube. Apply water-soluble lubricant or ointment to kind of help provide some moisture there. And then it's important to remember to do mouth care because they have this NG tube, so they're probably NPO, meaning they're not drinking, they're not eating anything by mouth. So we want to make sure we're still taking care of their mouth, having them brush their teeth or whatever. If they need you to do it, help them with that. And then some clients can have some like ice chips or maybe like a moist cloth. Some places have like little swabs, or they're like little sticks with little sponges on them, and you can kind of get some water on that and let them kind of moisten their mouth. But you have to be careful because sometimes they'll be sneaky and they'll just try to suck all the water out of it. And, anyways. So you got to be careful. You just want them to know that they are just using that to moisten their mouth. But you do have to have a physician order for ice chips. So it's important to irrigate a nasogastric tube to make sure it's staying patent and not getting any clogs in it. but specifically we're going to talk about irrigating when it's connected to suction. So again, we're going to do all the things that we do before doing any kind of patient care. Prepare client and equipment, provide privacy, protect the bed, so towels, pads, whatever, to kind of just protect it from getting anything on it. Hand hygiene and gloves. Patient should be in semi-Fowler's position. We're always going to check the placement of the NG tube. Drop the amount of the irrigation solution. So should be like 30 milliliters to 60 milliliters. Just kind of depending on what you need and if the patient's on a fluid restriction or anything. And then you're going to clamp the NG tube near connection site, or just unhook it from the suction, turn off suction and disconnect tube from connector. And then you're going to place the syringe in the appropriate lumen. So if you have a Salem sump, you're going to put it in the clear part, not the blue part. And then you're going to gently insert the solution. You can do this just by gravity. And then you're going to reconnect to suction and observe return of the drainage. So you want to make sure that comes back out, the solution that you just injected. And then if there needs to be more air in the blue air vent, you can do that as well. So then just use your same syringe, drop a little bit of air, and just inject it into that blue air vent so you can reestablish that so it doesn't cause a suction. Okay, just kind of reiterating appearance of gastric secretions. So normal gastric drainage has like a mucoid, like kind of mucousy consistency. And it's either colorless or yellow-green. Sometimes it is kind of a brown color as well. It could be coffee ground, meaning it looks like coffee grounds and like a dark brown color. Or it may just have what looks like coffee grounds in it. This would indicate bleeding. So usually that means that old blood. So it could be from like a lower GI tract bleed. Anyways, so that could indicate that. Some blood may be expected after GI surgery. So if you get a little blood out of that and they've just had a GI surgery, that might be a normal finding, but you want to be assessing the secretions to look for anything abnormal or any complications. Okay, so when it comes time to discontinue the NG tube, you want to make sure first that you have an order for it. Again, you're going to explain the procedure to the patient, put them in a sitting or half Fowler's, semi-Fowler's position. Then we're going to turn off the suction and separate the tube from the suction device. And then we're going to remove the securement device, so however we taped it on the nose or secured it to the nose. And then we're going to fold the tube on itself. So most of the time they don't have like actual clamp on them, so you may just want to fold it or clamp it off however you can with that tube, so it doesn't leak out gastric contents. And then you're going to instruct the patient to take a deep breath in and hold, and then you're going to quickly remove the tube, okay? So you don't want to do this slowly because they probably can't hold their breath for that long, and then it increases risk for aspiration. So just kind of do it in a slow or a quick, steady motion, okay? You definitely want to make sure that you've got towels, pads, whatever, covering your patient, because there's probably going to get some gastric contents on the bed or whatever when you pull it out. And then you're going to observe for intactness, so make sure it's all still intact. And then you are going to dispose of the tube per policy and then document that you removed it and that the patient tolerated the procedure well. The NG tube was still intact. All right, so follow-up evaluation. So you're going to check for presence of bowel sounds, any nausea or vomiting, intactness of the nerve tissue, because that creates pressure on on the nares from the NG tube, so you want to make sure that it's intact. Relate the findings to your previous assessment data. So if you need to compare, to when they had the suction going, they weren't nauseated and now all of a sudden they're nauseated again. And then you want to report any significant findings to the physician. All right, there's other type of tubes that are used for feeding. These are not something that we place, but it's something that you could definitely be caring for someone with. So there's a gastrostomy, a jejunostomy, percutaneous endoscopic gastrostomy, or a PEG tube, and then a percutaneous endoscopic jejunostomy, or a PEJ tube. And we're going to talk about the differences. Okay, so this is a picture of a PEG tube. You will probably see patients with this. So this is for patients who, for whatever reason, they can't eat or drink, get their nutrition orally. So they have this put in surgically long-term to get their medications through it and nutrition through it. And then so for the PEJ tube, the end of it is just going into the jejunum rather than just into the gastric body of the stomach. Okay, and then this is just kind of a picture here showing where each type of tube, would be and the differences. Nasogastric, we talked plenty about that. So through the nose to the stomach. Nasointestinal, this goes through the nose and then into the small intestine. Gastrostomy, this is surgical through the stomach wall, or endoscopically would be a PEG tube. So that's just another kind of a gastrostomy tube. And the jejunostomy, either surgically through the abdominal wall or endoscopically. Okay, so now we're going to talk about administering tube feedings. So this is very important that we know how to do this safely. We will have a lot of patients who are getting tube feedings, if they are having issues with swallowing. A lot of times they will have this. Also, patients in the ICU when they are, on the ventilator, intubated, sedated. This is how they get their nutrition. So you'll probably see these a lot more in the ICU, but could definitely see them anywhere. These same concepts, for the most part, would apply to giving medications or feedings through a PEG tube as well. So just kind of keep that in mind. Just PEG tubes, we don't have to worry about the huge risk for aspiration that's associated with NG tubes, but we still do need to be careful. Okay. So you want to make sure, again, that they are correctly positioned. So they need to be sitting up pretty high. You're going to, again, assess for tube placement. Because if our tube has moved and it is not in the stomach and by the lungs or whatever, and you give them a bunch of feeding, it's going to go into the lungs, and then they are going to go into respiratory distress or even respiratory failure. And you're going to check residual. So what I mean when I say this is I'm going to get my syringe, my piston syringe, and I'm going to draw back and I'm going to see how much of their stomach contents comes out. So if they have been on feedings for some time, they might have some residual, okay? So if I'm pulling back and it just continues to come out, I'm measuring it. If I have 100 mils or more, I need to let the physician know. And then they may tell us to hold the feedings for a little while. Per agency policy, as far as returning the residual amount to the patient, most of the times you will. But this would be another thing you would ask the physician or follow your hospital policy. You want to check residual volume for continuous feedings at least every 4 to 6 hours. So some feedings are given continuously via a pump. So I know at St. Bernard's they're called kangaroo pumps, but they have special tubing, and you put whatever prescribed, feeding is. And then you have another bag that has like the sterile water in it, and you set it to give a certain amount of hour, and then with a flush of a certain amount, usually every hour, just depending on the order. So especially when they have this, we want to be very careful to check for residual, because if their body is not moving that food, that contents throughout their intestines and out of their body, it's going to just stay in the stomach. And then if we keep filling up the stomach, it's going to fill up, fill up, fill up. It's going to go up into our esophagus and then could spill into our lungs. So that is obviously very bad. I have unfortunately seen someone, code from aspirating. They were on continuous feedings. I'm assuming the nurse was not checking their residual like they should have been. And they did end up aspirating and coding. I believe they came back, but anyways, she could have died. So that was a very serious complication of NG tube feedings. So you also need to know the rate. So if you're giving intermittent feedings, we want to use that piston syringe. Take the plunger out of it. As you can see in this picture, it's just a syringe. It does not have the plunger in it. And then they're just pouring the solution into here, okay? And then we're just kind of regulate that by gravity. So holding it up higher is going to make it go faster. Lower is going to make it go slower, okay? You don't want to use the plunger to force it in super fast. And then make sure that the patient stays upright throughout the feeding and a minimum of 30 minutes after, but ideally 1 hour. So this is for intermediate feeding, so maybe they have it every 6 hours. Or if they have it continuous, then you really want to make sure the head of their bed is always at least 30. If you do need to do any maneuvering with them, turning, laying flat, whatever, you need to pause those continuous feedings while you're doing that to prevent risk of aspiration. Okay. Okay. So important things to note is, again, rate of administration, how fast you're giving it, making sure the patient stays upright for at least 30 minutes. Head of bed should be 30 to 45. Check placement and check residual. In the notes here, it has the specific steps listed. I also have like a skills checklist in Canvas that you can look at that just takes you through just step by step, kind of the order of how to do the procedure. So make sure you look at those. Okay, so if we are giving medications through an NG tube, same kind of concepts. We're going to make sure that their head of the bed is elevated. We're going to check for placement. If they are hooked up to suction, then you're going to clamp the tube or remove it from the suction. And then after you've checked placement and all of that, you can go ahead and flush the tube. So with your piston syringe, just flush it with 15 to 30 milliliters of water. And then you're going to give the medication. So sometimes they're liquid, a lot of times they're pills that have to be crushed and then mixed with a little bit of water and then poured into the piston syringe. So that might be, that's probably what you'll be doing. So that's how you give the medication. So you'll pour those in, let them drain in by gravity, and then you'll flush again with another 15 to 30 mils. So that way it all goes into the patient's stomach and nothing gets stuck in there and clogged up. So you want to flush before and after. Now, if the patient is supposed to be on continuous suction, then we are not going to immediately hook them right back up to suction after we've given meds through their NG tube. Then this will just suck the medications right back out, and they won't get the effects of those medications. So if they are hooked up to suction, you need to leave them unhooked from suction for at least 30 minutes to give time for the body to absorb the medications. So I usually just suggest, setting an alarm on your phone for 30 minutes. And then that way you get alerted, when 30 minutes has passed, you can go and, do your other stuff in the meantime and then go hook it back up to the suction. If they're not hooked up to suction, then you would just clamp it and leave it clamped until you need to use it again. Okay, and again, we've talked about the complications. I know I've talked a lot about aspiration, but that's probably the most severe, complication that can occur if the tube gets clogged. Nasal erosion, so just from that tube being in the nair and irritating it. Diarrhea or other GI symptoms, unplanned extubation, so if it comes out, either the patient pulls it out or it gets hung on something, that can happen. And then unfortunately, usually we have to end up putting another one in, and that's a very uncomfortable process for the patient. And then infection could occur as well, although it's not common. Okay, so again, just make sure you review your resources in Canvas going over this. If you have any questions about what I've said on this lecture, feel free to email me and reach out.